Griffin.
And I'm Dixon DePommier.
And today we're going to be discussing gastritis and reflux.
Two of my favorite topics.
And I will subtitle this to be distinguished from peptic ulcer disease.
Oh, yes.
But that might be up to us to distinguish. So you said these are your two favorite? These are your two favorite?
Well, tests? I've had bouts of each. So
okay.
If you want me to recount my life story again,
were they
how
your,
boring
were they
can
your
you get?
fault? Were they your fault, do you feel?
No, I think they were the fault of what I just ate. A lot of Italian food, for some reason, repeats. Everyone says it repeats. You can tell what you've had 10 hours after you've had the meal because it's got certain aromatics that stick around. And occasionally, not often, but occasionally, when you're trying to go to sleep and you've just eaten 3 hours beforehand, you do get a reflux every now and then. And the older you get, I presume, the more frequent that occurs, although I'm not sure. That's what we're going to find out.
Yeah, I like the way you put that together because I like to say that many causes of heartburn and gastritis are consequences of behaviors, but I don't think you're to blame. But there are certain, nobody's fault.
Or the chef.
But education regarding the links between certain behaviors and this consequence can be helpful. So there are certain activities that people might engage in that might lead to symptoms.
Correct.
One of them, and this I will say is your fault, is smoking.
Yes.
One of the things about smoking is it'll actually relieve the pressure of the valve at the upper part of the stomach. And when it relaxes, the acid will come up and will give you that feeling of heartburn or reflux. So
the cardiac sphincter.
So that would be your fault. Now, it's interesting, you call it the cardiac sphincter, and that is the name, but it's confusing. Is it the heart sphincter? Why do we call it cardiac?
It's closer to the heart than the other one.
So the reason they actually call it cardiac is that part of the stomach, is the cardiac part of the stomach. And so that's why they call it the cardiac sphincter. It does not have to do with the heart. Oh. So no, but that's a good. So that sphincter, the lower esophageal sphincter, can actually relax. Alcohol ingestion. So these are, you start putting together these things, you'll realize so you have a couple drinks. A person
you
might
have
have
a party,
drink,
and you come home, it's late.
They eat dinner and they have a drink.
That's right, that's right.
Drinking of coffee. Maybe someone has their espresso or tea, or so caffeine can also relax that sphincter.
Oh dear.
Spicy or acidic foods can also lead to symptoms. Laying down soon after one is eaten. So again, you have your large meal.
Not a great idea.
Maybe the person smokes with it. I'm going to frown on that. Maybe they have an alcoholic drink. Maybe they have an espresso or a coffee or a tea. Maybe the food was spicy, and now they lay down. So there's a lot of behaviors that can be actually triggering these certain medications.
Really?
Someone might take aspirin or ibuprofen or naproxen. So certain medications actually can also make these symptoms worse.
I'll be darned.
So what causes gastritis and reflux? Probably should get at that. So I feel like we sort of alluded. One of them is when you have acid getting from the stomach up into the esophagus.
Yes.
And that can happen either because there's more acid or because that sphincter is relaxed. Gastritis can actually be irritation of the stomach. Itis, so gastritis, inflammation of the stomach.
Of course.
And I said as the subtitle, we want to distinguish this from peptic ulcer disease.
You bet.
So peptic ulcers, what are peptic ulcers?
They're a thing of the past. Now that we know what causes them.
So that is interesting. When I was in medical school, the surgeons were still teaching the section on peptic ulcer disease. And they were a bit uncomfortable because the teaching had been for many years that what caused ulcers, and these are actually erosions through the lining of the stomach or small intestine, was too much acid. And a lot of their treatment, too much acid.
Sounds like a scene out of a movie that I once saw. It was called, it was about Mozart. And Salieri sees one of Mozart's pieces and he says, too many notes. And he throws it to the ground. Too much acid, I'm sorry.
And so the surgeons, there is a famous clinic out in the Midwest, the Mayo Clinic.
Oh, yes.
And actually a large part of their business was doing ulcer surgery.
Unbelievable, isn't it?
And then there was a clinician who realized that the majority, I should say half to the majority of peptic ulcer disease, I'll say the majority worldwide, was due to an infection.
Yes.
So we're not going to talk about Helicobacter pylori here, but that is the number one cause of ulcer disease throughout the world, and it's an infectious disease.
Exactly.
It's not too much acid, it's an infection. But what we're talking about is non-peptic ulcer disease. Maybe we'll talk about that on a separate occasion.
Right.
But we're talking about gastritis, so not a localized ulcer,
Right.
and we're talking about reflux. In more resource-rich areas, you start to see ulcers from excessive use of your naproxen and your aspirin and your ibuprofen.
Right.
So, but again, we're going to talk about our gastritis, which actually can be made worse by those as well, and our reflux, which can be made by worse.
Absolutely.
So how do we make the diagnosis? Is it a clinical? Do we need a lot of money?
Wait, I'm the patient. You're the doctor.
Yeah,
I don't know the answer to that.
So you were telling me before that you had gastritis. Did you have to go to the clinician and get expensive tests to make this
No, the
diagnosis?
gastritis wasn't more my problem. It was acid reflux. It was basically my problem. And a breach of the esophageal barrier, so to speak. Mm-hmm. And if you've ever had one, you'll never forget it, because stomach acid is really acidic, even though it's hydrochloric acid, and it's one of the milder acids that you can think of as compared to nitric or sulfuric acid. It stays with you a long time. It invades your nasal passage. If you're unlucky enough to inhale a little bit of it, it irritates the esophageal epiglottal area. It's a horrible, horrible thing to experience. It's like throwing up, except that you're not throwing up, just the acid part of it comes out. And it was horrible. Horrible. Did I do a good job of describing
I think you described it well. And one of the reasons that I think we call it heartburn is that it is. It is like your heart is on fire.
It is a burn.
People, maybe the first time they experience this, coming quite frightened.
Yes.
Because of the severity and the fear that come from it.
I can't believe it.
So it can be quite debilitating. It can be quite upsetting. It can be quite fear-provoking.
Sure.
Because it is. You have stomach acid, which has gotten up into the esophagus,
Right.
and the esophagus is now basically letting you know.
Exactly. That it doesn't like that.
Yeah. So a lot of the diagnosis is actually symptom-based.
Ah.
People come in with, as you described, what we say is typical burning symptoms.
Right.
It's it's radiating up into the chest.
Right.
It's often in someone who's presenting for the first time at a relatively young age. 20s, 30s, usually at an age before. Usually by the time they're in their 50s, 60s, they've gotten quite used to this. And the distinction in part between gastritis and heartburn might be the timing. Gastritis often gets better when we eat. The reflux, gastroesophageal reflux disease, or GERD as we call it, is often made worse by a large meal.
Interesting.
By all the precipitants we talked about, the smoking, the alcohol, the laying down.
Right.
But like many of the diagnoses that we talk about, many of the common complaints, we want to make sure that something which is, well, quite uncomfortable, but not life-threatening, is distinguished from things that are life-threatening. So we want to worry about what we call warning signs.
Right.
And warning signs actually here are similar to warning signs we see in other areas. You might have weight loss. You might have blood in your stool. You might have black tarry stools because the blood is in the upper part of the tract and it's being digested. Right. And you might have black stools that have a sweet smell. So there's actually a characteristic recognizable odor to the melena, the black stools of an upper GI bleed. And those you want to be careful to distinguish, as well as ulcers. An ulcer could actually erode right into a blood vessel and can be life-threatening as well. Of course. So any patient with blood in the stools, black stools, or weight loss, they need further workup. They need referral to a higher level of care or evaluation if you're able to do that.
Right.
Well, what have you done when you had your gastritis?
No, I didn't have gastritis. I had
your
acid reflux.
Okay.
I mean, I suddenly woke up out of bed and rushed off to the bathroom thinking I was going to throw up.
Okay.
And I didn't. What I did was I developed this awful acidic burning sensation in my entire pharynx. And it took I was up for the next 2 hours. I would go in, and I watched a lot of wonderful nature shows at around 3 o'clock in the morning with David Attenborough telling us all about how the penguins make it back to their, that sort of thing. And then in 2 hours, the burning sensation had dissipated. I was still sleepy. It didn't help with that. And then I gradually went back to bed, and it didn't happen again.
Okay.
But I can recall at least 3 or 4 incidents like that over the last 5 years of my life where I was really.
Now we talked about some of the precipitants of your reflux disease. Had you done anything that might have led to this? That wasn't your fault.
No. I finished eating late.
So you
ate around 9 or 9:30, and I was sleepy, so I wanted to go to bed right away.
So you laid down soon after eating a meal.
I laid down soon after eating a meal, and that was the thing that I'm sure led to it, because your stomach sort of shuts down when you go to sleep. The blood supply leaves, goes somewhere else. You're not supposed to be digesting your food when you're asleep. And that part I knew. And of course, why did I go to bed? Because I was just tired, I guess. And I paid the price for that, unfortunately.
Well, so what I'll say is one of the first things that we recommend, again, before we start throwing the drugs, before we start encouraging pharmaceuticals, is looking at prevention.
Right.
And in a lot of cases, patients are aware of a connection like that. They've had a large meal, or they've laid down soon afterwards, or they've done one of these mints also. A mint can also relax that as well.
Oh.
Or chocolate can do it as well. So one of the first things you can do to prevent this from recurring is go through behavioral changes.
Absolutely.
And if a person can make these behavioral changes, they are at less risk of getting reflux.
Yep.
So that's good. Gastritis is going to be slightly different. It's going to be more of a certain foods, spicy foods, acidic foods. So again, that could be changes in dietary choices, which are not always possible.
That's true.
To be realistic.
So I was raised in San Francisco area, but remember I said I was born in New Orleans. So you're born with a bottle of hot sauce in your hand, basically. And so I'm totally tolerant of any hot and spicy foods. I don't have gastritis, that I do know. I've tested that hypothesis many times, and it just doesn't work out like that. But the reflux that's different.
So one of the things that we're still right before we jump to treatment, sometimes people use treatment to make the diagnosis, and there are empiric trials. If someone comes in and the story sounds reasonable for gastritis or for reflux, sometimes we will actually treat them to try to clarify the diagnosis. And so there's a couple different ways to do this. The normal is to use one of our protein pump inhibitor therapies. This would be something like our omeprazole or the equivalents, pantoprazole. And these are actually going to shut down acid production. And we usually recommend a 6-week trial if you're trying to clarify the diagnosis. Because one of the things I think we have to realize, are we going to put someone on lifelong therapy? Hopefully not. But before we go to treatment, that's one of the times we'll often do an empiric trial. We'll do that for, we'll say, our 6 weeks, and then we'll bring a patient back and say, did that make things better? And if they come back and say, you know what, when I took that can help us confirm. Because we really don't want to be sticking endoscopes down, doing a lot of expensive tests in what is an incredibly common complaint.
Yeah, that's true.
But now let's talk about treatment. And we already kind of got into this. We're going to talk about dietary and lifestyle modification, as we like to say. One of the things we recommend that I've never found to work is the idea that you're going to elevate the head of the bed. So somehow people are going to be sleeping at a tilt.
I can't do that.
Many of us sleep in a bed with other people, and so
This is all
suddenly we've become quite the
They make beds now with one or two, you can adjust both of them, so that's no longer the problem.
So that's interesting. I like the way you showed that. So those beds, do they bend at the waist, or
No.
does the whole bed?
No, well, they do bend at the waist. The ones that I've seen bend at the waist.
So that's a bit of a problem. If it bends at the waist, what you're going to end up doing, you may be getting gravity, but you're actually going to be compressing the belly, and you're going to be pushing. So that's what if you are going to go ahead with the incline bed, then you need to incline the whole bed, not a bend at the waist.
You have to strap in order to not slide out.
So I have occasionally had success with that. I'm always surprised when the patients tell me they've gone ahead and done that.
That's interesting.
But then there are other things we can do. One of the quick remedies, Tums, calcium carbonate.
I used to.
Right, those are
like
actually
Tums.
quite common throughout the world.
Yeah.
And even when you give all kinds of advice and people are doing things to modify their risk, they still will likely have periods of time when they'll have problems.
Of course.
And the Tums can be helpful for those exacerbations, those acute gastritis or acute reflux problems. Sometimes if it's severe, we'll actually go and we will use the medicines that we talked about, the omeprazole, the protein pump inhibitors. And so you need to decide, is that going to be part of your pharmacy that you're providing? Because these can be quite expensive. And in certain situations, people use our histamine blockers, things like cimetidine, which Pepcid in certain areas. So yes, but again, to reiterate, we're going to focus first on lifestyle and dietary modification. If that fails, we might give symptomatic occasional therapy with our calcium carbonate, and then we might go to other medicines. And if all this fails, then you want to again be looking at who can I refer to? Is there a higher level of care? Because certain times, particularly if they have warning signs, you're going to want to get them to a higher level.
Right. So the way we solved it in my house is that we started dinners earlier.
Which is a fantastic and commendable solution.
And no more reflux. We're set.
Excellent. All right. Well, thank you for joining us, and I hope none of you suffer from reflux or gastritis.
Me either. See you next time.
All right.